There on that frog leg view, I see some lucency kind of in the subtrochanteric region. Yes, there. But I don't, well, it might extend there through the intertrochanteric region. I think it's suspicious for an intertrochanteric fracture. And here we have the corresponding MRI, and we can see that linear decreased signal extending from the greater trochanter to the lesser trochanter, although there's no definite cortical breakthrough on the lesser trochanter, but this is compatible with a fracture.
Yeah, so this is
a bit comminuted, but
so how do you treat these, John?
Pardon me?
How do you treat these intertrochanteric fractures?
Depend them about a half an hour.
Okay, and here's another similar patient with an intertrochanteric fracture. T1. This is one of the early stir images that were obtained where you can see the edema pattern there. And just some other examples of this is more of a comminuted type intertrochanteric fracture. Here we can see it on the sagittal images, the different fracture images. With here an avulsion of the greater tuberosity or greater trochanter.
We don't deal with those. We put them as is.
Okay.
Usually they don't fall apart.
Good. Okay, Ashu, what do you think of this one?
Well, 74-year-old female with Parkinson's slipped on right kitchen floor, found down with her knee against her forehead. We see a dislocation of the femur inferiorly there. Relocation was difficult, anterior head and posterior acetabular fractures. Now it looks like it's back in the socket though. Here you can see a posterior acetabular fracture.
So I think it's a different patient. I'm sorry.
Oh, okay.
So here's a fracture dislocation in this particular patient. Here's another posterior fracture here. Okay. Okay, here's a patient who had right hip pain. Michael had right hip pain, and with negative X-rays, and they were concerned about the right proximal femur. Here's a bone scan, and here we can see the proximal femur down here, femoral down there.
Yeah, so I mean, you have uptake bilaterally in the pelvis. You can barely see the femurs, like the more distal femurs, or I can, at least on this screen.
And you can kind of see the ilium. It's really the sacra that you have a lot of uptake bilaterally. Here's the MR scan.
So in the MR scan, so there's abnormal signal, like hypointense signal, like it looks like fracture lines in the bilateral sacrum.
Right.
Like the back of there and on the kind of axial images.
Yeah. See here and here. So this is a patient who just presented with right hip pain, only right hip pain, and the problem actually were bilateral sacral fractures.
Yeah, bilateral sacral fractures, and a lot of times you get that transverse fracture going through, and that's where you get that Honda sign. But I don't really see that on this one.
Right. Exactly. Right. Jennifer, what do you think of this case?
So on this patient, we can see some linear low T1 signal along the right subcapital region with diffuse surrounding edema and a hip effusion. So this is concerning for a mildly displaced subcapital fracture.
Yeah, we can see a little fracture line here, a lot of subchondral bone edema here. Okay. So this was a study in skeletal radiology, which they looked at the fat-suppressed T2 appearances of femoral head in what they called insufficiency fractures, and they divided them into three types. Type 1 was high signal intensity within the subchondral bone. Type 2, heterogeneous signal intensity. Type 3, low signal intensity within the subchondral bone. And then they followed them over time, and they found those that had high signal intensity had 86% chance of healing. Those that were heterogeneous had 75%, but those with low signal intensity on all sequences had only an 18% chance of healing. What do you think's going on here, Jennifer?
So I think that high intensity subchondral signal probably corresponds with a bone contusion, acute marrow edema, whereas with the heterogeneous to low signal, the low signal would be more indicative of a fracture, fracture line, and probably some perhaps some impaction, and those would be less likely to heal.
Right. Yeah, and the type 3, where everything that's low signal intensity, tend to be chronic disease, whereas where you have high signal intensity on the fluid sensitive images, you're really dealing with acute injury. And so this basically is saying is acute injuries have a reasonably good chance of healing, whereas chronic degenerative disease doesn't, which is what you kind of expect. Okay, Ashu, what do you think is going on here?
All right, so we have two sets of scan coronals, and you can see that in the first set in May 2002, you see a significant bone marrow edema pattern involving the femoral head and neck of the left femur, and then you can see it resolving, well, mostly resolving in June 25th, and this is that transient marrow edema.
Okay.
Oh, there's a little bit of increased signal there, but it's mostly resolved.
Yeah, so this is classic transient bone marrow edema, but you can see there's a little bit of a subchondral impaction, very subtle there. These patients like that physician's assistant I showed yesterday tend to have a pretty good prognosis. These are just the sagittal images, T1s.
Okay. If you leave them alone.
Right, if you leave them alone, right. If you let them heal. Michael, what do you think of this one? Right hip pain.
Right hip pain. So we see edema on the stir images up in the and like the kind of central acetabulum. The femur itself looks okay. The T1 weighted images is just kind of indistinct blob. I don't see like a definite fracture line extending into the cortex. And do they have any other history, like trauma or insufficiency fracture of acetabulum?
Their just hips started hurting.
Yeah, so I'd worry about a trabecular bone injury, and this is from insufficiency fracture.
What would you do with it?
This one, well, one, you need to treat their underlying osteoporosis, but I mean, I don't think you do anything specifically for this other than I guess rest. Don't break it further.
Non-weight bearing.
Yeah, exactly.
I just want to remind people that if you sit, you're actually putting a lot of pressure right through this region. So sitting really is not the same thing as allowing this to heal.
Well, John, if it's causing pain, which this would, if you sat, you'd know about it and you wouldn't do it.
Right. Yeah.
And getting in and out of bed would be painful too.
Right. Right. Jennifer, what do you think of this patient?
Well, I don't see any significant marrow edema within the femoral head or the acetabulum. There is a region of focal cortical irregularity along the superior acetabulum. So I want to look at the rest of the images and see if that's okay, so that looks fairly normal. It's well defined. I think that's a supraacetabular fossa, and this can be a normal variant.
Right. So you can get a normal variant right here at the 12 o'clock position like this, or a little bit over, more toward kind of halfway between the 12 o'clock position and the fovea. So this is called a supraacetabular fossa up in this location. Let's see, we'll see some more variants here in a minute. Ashley, what do you think of this case?
30-year-old female runner with right hip pain after a fall. Looking at this, I think there's some irregularity near the greater trochanter on that first image. Yeah, there's some lucency right there. Yeah, I'd be worried about an avulsion fracture, possibly. Looking here, is that the same variant along the superior acetabular or the medial?
Well, the one we saw before was right here at the 12 o'clock position.
Yeah, this is more toward the fovea.
So this is more medially located.
Yeah, and that looks like there's some chondral loss there, and there might be some. Is that just an impaction injury?
Yeah. This was also thought to be a normal supraacetabular fossa.
Okay.
Yeah. So you can have variants there. Now, when you get pelvic fractures, there's a classification called the Harris classification, where you can have isolated pelvic fractures, but if it's of the actual pelvic ring, as you know, you typically have to have injuries in two locations because it's a ring, unless it's an avulsion injury. I'm going to go through that. So
never use it, John.
Yeah.
Poor hair finally got some kind of a notice here. So Salter Harris.
Mm-hmm.
Canadian.
Yeah. Michael, what do you think here?
Okay, so 23-year-old male, right hip and thigh pain for 1 year, popping during soccer. So one thing I noticed, on the right, along the kind of lateral aspect of that acetabular ridge, it looks like there's extra bone density right there, exactly, that we don't see on the left. And now you're showing me, I guess, the muscular. So that's probably a tug lesion.
Okay.
And there's soccer, and if I assume if they're right side, if they're constantly kicking with the right leg.
What attaches here?
What is that?
What attaches there? I mean, it looks like you're showing like part of the quadriceps.
And do you know what tendon attaches here? There are actually two heads that attach here.
Rectus femoris.
Yeah, the rectus femoris is the one inferiorly, and then the sartorius is superiorly, correct?
So this is an avulsion injury at the rectus femoris tendon attachment. Let's look at some other changes here. Jennifer, what do you think of this particular patient?
Okay, so here we have some axial and coronal images of the hip, and here it looks like there's an osseous avulsion injury of the anterior superior iliac spine, compatible with avulsion of the sartorius.
Yeah, I think we're pretty low here. I think this is the top of the acetabulum here. The patient had.
Oh, okay, so we're still at the rectus femoris then.
Yeah, I think we're still at the rectus femoris. Well, I've got a lot more to talk about rectus femoris insertion, but I guess that's later in this lecture. Okay. Let me see. Ashu, what do you think of this case?
Well, based on what was circled on the next image, we're looking at a fat-containing or a very bright T2 or T1 lesion along the acetabulum. I think this is a lipoma. Could be a melanoma. Oh yeah, and it fat sets out, so it's a lipoma.
Yeah.
Right
So
there.
this is a lipoma within the joint space there. Good. Okay, Michael.
Okay, 71 female, pain for 1 month. So we see on multiple images that there's these like expansile soft tissue lesions in the bones, and the axial CT up on the top, we see it looks like there's one in the sacrum, kind of expanding it. Looks like there's cortical breaking as well. And then down in the pubic rami, there's kind of expansion and cortical break. I mean,
that's severe osteoporosis. That's severe osteoporosis. Look at the hips.
Where are we gonna, like on the plain
And
film?
the prior film right there. Yeah, look at the hips. So they look normal.
Well, here you can see the cortices look very dense here. That's really because you lost a lot of trabecular bone due to the osteoporosis, right?
And is there just osteoporotic fractures?
Is that what you're calling this?
Well, I wasn't sure. Like on the pubic ring mount, almost looked like there was like soft tissue density within it, but I guess that's incorrect. So these could just be. I mean, it almost looks like there's bony destruction.
Okay. And what about the sacrum?
The sacrum, like I don't see the cortex superiorly along the right side of the sacroiliitis. It just looks gone, and fractures there.
So what do you think's going on here?
That almost looks like is this a enhanced T1, like that almost fat set T1, like that almost looks like a rim enhancing fluid collection.
Okay.
So I don't know, this could be infection of some sort.
Here's that.
And it looks like it might have some debris in it, or just osteolysis. Yeah. Okay.
So this was a patient who actually presented with osteoporosis, a chronic large fracture of the symphysis pubis region, and actually in the iliac inferior pubic rami, also bilateral stress fractures involving the sacrum back through here, and then this got infected, and that's what you were looking at there. This is actually and secondary infection with an abscess.
Did they look like coxa magna on that one first right there, John?
I think the both femur are rotated here. I don't think there's actually coxa magna.
Okay, and it just caught my eye. I thought there might be.
Sure. Yeah.
If you compare the hip here versus the one back there, it's kind of elongated. And
I think it's positioning.
Okay.
Okay, Jennifer.
Okay, so here we have a 71-year-old male with right hip pain for 1 month. There's some lucency along the right lesser trochanter. I can't tell if that's artifactual on the single image. And then here we're looking closer at that right hip. I don't see a discrete fracture. Here we can see that there's edema in the right iliac bone, and it looks like there's some surrounding low signal intensity.
Okay. So there's a displaced fracture of the right iliac bone. Here's the normal on this side. Here there's a fracture line there and displacement of the iliac.
Iliac fracture.
Yeah. So here it's really hard to see on the plain films, but it's a lot easier on the MR where you can actually see the displaced bone and the fracture. And on the axial images, it's very obvious.
Yes, I can see it there.
Yeah. So hip pain.
It's gotta be painful. That area is very painful.
Yeah.
That's why we in orthopedics, doing a graft is not something to joke about. These areas are very, very painful when you take the graft.
Okay.
In fact, the site where you take the graft from is more painful than the wound, almost invariably.
Wow. Ashu, what do you think of this one? Right hip pain.
Right hip pain. On this single views pediatric patient, don't really see much abnormal here.
Epiphysis
This
head.
looks kind of abnormal. Almost looks like the femoral head. This could be SCFE, a slipped capital femoral epiphysis, where the femoral head is kind of slipping down inferiorly.
Yep.
There.
Good. Very good. Here's the frog
Yeah,
leg view on the
that's much
left.
more clear on the frog leg view. So.
Yeah, that's a typical displacement pattern of a femoral capital epiphysis lesion, SCFE lesion. And there are measurements you can make, but there we go. Generally, most people don't make these measurements. You can eyeball it and actually give a displacement, an average displacement of how far the margins of the femoral head displaced with respect to the metaphysis, both posteriorly and anteriorly. But if you do want to make a measurement, it's called the torsion angle. And here, if you put a line along the long axis right through the middle of the neck of the proximal femur, and then you also draw a line bisecting the epiphysis, they really should be collinear. And if you have the epiphysis rotating with respect to the long axis of the neck, then this is called the torsion angle. And anything over 20 degrees is considered abnormal. Okay.
What I do is look at the neck and attaching to the head. When it's above the head, that to me is a slip.
Okay. Yeah. So
we never measured.
Yeah, the normal, the epiphysis should extend above on the superior side and below on the inferior side the metaphysis. The epiphysis should really cover it. If it slips to one side like this, that's abnormal. And here, there really should be a little bit of a displacement superiorly when you go from the metaphysis to the epiphysis. And here, there's actually been a slippage, so you're not seeing that. In fact, this is abnormal on both sides, where you have slip capital epiphysis on both sides. And you can see a significant rotation here on the sagittal images.
One of the problems with these is when you pin them, you usually try to use individual wires. And nowadays, the screws that you use are hollow, so you can put a K-wire and position it and then pin it. If you try to manipulate these, you can cause avascular necrosis. It's a very tricky business. You're better off putting them in place rather than try to manipulate them. You try to pull on them too much, you damage the vascularity, and you wind up with AVN. I'd rather have a little bump there to remove later. I think we'll be talking about that later on, but and that's one of the problems is treatment.
So here we can see SCFE on one side, the other side is normal.
Yeah, you would think, well, fix it. Well, this guy put in one wire, one device. It's not enough. Well, it looks like one device. Maybe it's two, but
I think it was just one. But you can get rotation if you just have one device.
You have to have two, because you have to prevent rotation.
Okay.
Whoever did that was an amateur.
See, who's next? I forgot. Is it Michael or Jennifer?
I think it's me.
Okay, go for it.
So 10-year-old male, left hip joint pain for 1 month. So it looks like there's kind of abnormal configuration of that femoral head, like the epiphysis. So I assume this is another example of SCFE. If we look at any of the frog leg views, yeah, especially on the image, these frog leg views, you can see that it's like markedly slipped, like almost 50% I would say, or like 40% uncovered. And then on the MRI, we can just see that as well. There's a joint effusion, significant signal within the epiphyseal plate, and then it's angulated posteriorly in relation to the distal aspect of the femur.
Here you can see the normal on the right and the abnormal on the left.
Yeah, so that's pretty. And now it looks like he got pinned, and it appears to be in better alignment. It still looks maybe slightly, not exactly 100%, but much better alignment than before.
What do you mean alignment?
With the metaphysis, with the epiphysis on
Yeah.
the next image, there's just a tiny bit of
It's
like,
still
like a millimeter.
It's still rotated to the right. I mean,
Yeah,
rotated externally. But the one pin is, like I said, is not enough. One thing that you will notice on the slips, you don't see the lesser trochanter as well, and that can give you a tip off on a slip capital. If you look at the first film, well, this was not positioned.
Yeah, this one, right. Right. Yeah, we don't see it on this one.
Okay.
Okay, Jennifer, what do you think of this case?
So here there is some chronic appearing medial and inferior subluxation of that left femoral head epiphysis. This looks like probably sequela of chronic SCFE. It looks like the physes are closed. And here again, we can see chronic appearing subluxation, and there's some impaction and anterior angulation.
Yep. So that's old slip capital femoral epiphysis. Okay, Ischio. This will get to what John was talking about earlier.
So slipped capital femoral epiphysis, June 13, 1998. You can see that there's coxa deformity. There's foreshortening of the femoral neck. There is abnormal angulation of the epiphysis as compared to the metaphysis. This looks more on the chronic side.
Okay, so this was June 13th, 1998. You see a nice normal on the left. Okay, and here they put in 2 pins. So what do you see here?
It looks much better in terms of the coxa is resolved. The pins are in place. There's good angulation. The epiphysis is in alignment with the metaphysis here.
So this was a day of surgery.
Now all you have to do is pray.
Post-op.
All you have to do is pray now.
John's praying. Okay, this is 1998. Here we are 4 years later.
Great.
They didn't pray. They didn't pray, John.
I didn't pray enough. There's significant lucency throughout the right femur, probably some disuse osteopenia, and then of course the superior aspect of the femoral epiphysis there looks like there is an osteochondral injury, a fracture, and it looks unstable.
It's AVN.
Yeah, definitely AVN. Yeah.
So the epiphysis became necrotic and basically just became destroyed, and we just see this big defect in the metaphysis.
The treatment was excellent, but the problem is they may have been a little too rough. You have to be really gentle with these. Don't put them in traction and yank on them. Although traction has been done on these to put it in position on a slow basis and then pin them. But the results, I'm not sure that are much different. The main problem is what you're looking at right here with with slip capital epiphysis, AVN.
Yeah. Okay, Michael.
Okay, chronic hip pain How old is this patient? Because I'm looking at like the epiphyseal pate is closed, but it doesn't look up. It looks, or I mean, it doesn't look normal at all. It's like kind of markedly irregular, like kind of jagged. So I'm thinking they might have had a SCFE and then it never got diagnosed or treated, and then it healed. Yeah, now if we look at the axial images, you can just see it's like the femoral head's like kind of dysmorphic, but the plate is pretty much closed. So it's like I guess the SCFE that basically healed on its own in an abnormal configuration.
Right, exactly. Okay, Jennifer.
Okay, this is a 43-year-old female with acute left hip pain. It looks like there's some severe left hip degenerative disease. I can see some marginal osteophytes and narrowing of the joint space, and there's also some right hip degenerative disease. I can't tell. There may be some thinning of that medial acetabular wall compatible with osseous remodeling. I don't see a discrete fracture on this image.
There's some protrusio on the right and the left.
Yes.
Protrusio.
You know, the acute pain comes from just a sudden movement. A lot of people will not notice anything until some kind of a jarring effect, maybe sitting down too hard or whatever, and all of a sudden they have pain and they think that there's something wrong. Well, there's something wrong for a long time here.
Okay, so here we have the MRI images, and they do have bilateral acetabular protrusio. Again, this looks chronic appearing. I don't see any definite acute fracture. And here we can see thinning of the medial acetabular wall and protrusio.
Yeah, so it's bilateral protrusio with secondary degenerative disease, and this is often called an autopelvis.
These are very difficult to treat, by the way. Protrusios, they're the hardest to treat. But the acetabulum and total hip replacement is the toughest part of the treatment in total hip replacement.
Thanks, John. Okay, Ashu.
12-year-old male, right hip pain for 1 month, soccer player. You can see that the alignment of the epiphysis and metaphysis on the right hip is abnormal. You can see a slipped capital femoral epiphysis along the inferior margin. There might be some remodeling, and it looks normal on the left. Just more images of that. You can see increased edema at the physis and extending into the femoral neck as well. It looks unstable.
Right.
You can see it's almost completely disassociated. Yeah.
Good.
You don't want to bend the hip in that fashion. If you notice how the pins are placed, that's not exactly what you want to do.
Yeah, I'm not even sure this one's in the bone there. I think it missed the.
We don't know. You have to put it in a frog leg.
Yeah. But even there, the epiphysis is up here. It's, if anything, it's just at the margin, but I'm not sure that second one is even in the epiphysis.
Yours truly has missed one too.
Well, John, I can tell you, I have never missed one in my life. Of course, I've never done one either. So.
Oh, hell, you've never been on an operating.
Let's see. Michael, are you next?
I believe so. So 55-year-old with left hip pain. So the left hip, first thing I notice is there's a joint effusion. I'm not sure if it's just positional from the fusion, but it looks like there's kind of under coverage of the femur by the acetabulum. Like the edge of the acetabulum is only around like 50% of the femur, and then there's some, you're starting on this like subchondral marrow edema and probably chondral loss compared to the left. So I'm wondering, yeah, now we can see like subchondral cystic change, sclerosis. Is this just kind of like a, like, is that acetabulum dysplastic, like mild dysplasia and then degenerative changes?
There you go. Yep. Yeah, this had some abnormal center edge angle. This was dysplastic and then had secondary degenerative disease as the patient got older. Right. Okay. Jennifer.
Large joint effusion.
Yep.
This is a 29-year-old female with coccygeal pain. They're concerned about a fracture. She does have negative serology, but positive lymphocytes in the CBC. And she had a vaginal delivery 5 months ago and an appendectomy 2 months ago, and she also has scoliosis. So there is a bone scan showing diffuse bilateral increased uptake along the sacroiliac joints. And then on the plain film, there is sclerosis along the bilateral sacroiliac joints, and it looks like there may be some osseous erosions along the inferior sacroiliac joints. I'd be concerned about a chronic sacroiliitis. This could be a chronic infectious process. So here we have some sagittal MRIs of the pelvis and coccyx.
Let me go for a minute. What do you call this condition in a postpartum female where you get sclerosis of the iliac bones bilaterally next to the sacrum?
I don't remember.
Osteitis condensans iliac.
Iliac, okay.
Yeah, and then here's the
this
MR
one.
scan.
Okay, this one I was worried there were some erosions. And she does have some edema surrounding the bilateral sacroiliac joints.
So what do you think is going on here?
Erosive changes. I think this is more suspicious for a chronic sacroiliitis.
Okay, so certainly I would be concerned about sacroiliitis. If it's a younger individual like this, I'd be concerned that this could be ankylosing spondylitis, or it could be inflammatory bowel disease.
It's a woman, and it's on one side.
Yeah.
It's a woman, and it's only on the lateral side of the joint. So it should be bilateral, shouldn't it? On either side, both sides of the joint.
Well, the edema is both on the sacral as well as the iliac side here.
Right.
On the plain films, we could see the sclerosis was probably on both sides as well, though it was mostly on the iliac side.
Yeah.
But this was...
And in women, it's pretty rare.
Yeah. So this was thought to be osteitis condensans iliac secondary to birth trauma of the sacroiliac joints. The rest of the workup was negative in that patient.
That's what I would call it.
Yeah. Ashley, what do you think of this? Go ahead, John.
For what it's worth.
Yeah.
I mean, I'm a bone doctor, you know.
Ashley, what do you think of this case?
Chronic hip pain. This is normal fat. Maybe some mild fatty atrophy of the musculature.
Yeah.
Okay. So here there's edema in the quadratus femoris. There might be a decreased ischiofemoral distance, ischiofemoral impingement. There might even be some signal within the hamstring tendons there as well. Quadratus, yeah, Ischiofemoral impingement.
Yeah, and here's a typical example of ischiofemoral impingement. This is an article from Toriani et al. And AJR, where you get narrowing, as you're all familiar with, between the femur and the ischium and the hamstring origins there. So there's the iliasaurus, quadratus femoris, and the hamstring attachment. So with this, you can get narrowing of the ischiofemoral space, narrowing of the quadratus femoral space, and you get edema of the quadratus femoris. The quadratus femoris space is distance between the femur and the hamstrings. The ischiofemoral space is a distance between the femur and the ischium in that location.
These make noise too when you flex and extend,
Okay.
and sometimes they can drive you nuts to try to figure out what's wrong.
Yeah. So here's basically anatomy in this location. And here are just some examples of edema and narrowing of the space there, the ischiofemoral space. In this case, primarily the quadratus issue, the quadratus femoral space there. And these can get very narrow at times. And so whenever you do hip imaging, you have to look at this particular space because it's often not thought of otherwise, and the MR scan can be very helpful for looking for narrowing of the space as well as edema within the quadratus muscle. Just more examples of this disease.
Before MR, John, we used to call these snapping psoas.
Okay.
But then we learned what that was.
Yeah, well,
MRI showed it.
Yeah, I'll show a true iliasaurus snapping syndrome later, which was slightly different, but it's hard clinically to differentiate these.
I know you will, but clinically it's very difficult to differentiate these.
Yeah. Some people call these extra-articular impingement syndromes around the hip. And if you don't see anything in the joint space, then these are the things you have to look for. But you need to talk about them in all MRs of the hips, especially ischiofemoral impingement. And if you don't specifically look for it each time, it's very easy to miss. Yeah, so it's usually the quadratus femoris space, which is the one that's usually the narrowest. Just examples. And there have been studies looking at the cutoff distances and so forth. But I think instead of using an absolute measurement, what's most important is really the edema within the quadratus muscle. Okay, but if you're going to use a measurement, let me go back here. These are the cutoffs for the ischiofemoral space and the quadratus femoral space that people use. So if you want to remember something, just 8 millimeters of the quadratus femoral space kind of differentiate between those likely to be symptomatic from those who aren't. But you should always look for the edema pattern too. Okay, I forgot who's next.
I think it's me.
Okay.
61-year-old male with right hip pain, numbness, and mass. So assume the mass they're talking about. That looks like.
Let me say something, Mike. Just a second. Ischiofemoral impingement is almost exclusively in females. The reason for that is that the female pelvis tends to be wider anatomically than the male pelvis, and that narrows the distance between the femur and the ischium. So you're primarily concerned about that in females. And then now let's go to this case. What do you see on this case, Michael?
Okay.
This is a male.
So it looks like there's like a large. It looks like that's bone where the ischium is. I don't know if it's attached, like if that's part of the ischium, but it looks like I'd want to see some other cuts. So yeah, so there's like hypertrophy and kind of abnormality of that right ischium. It's not edematous compared to the left. So I would assume this is like they probably had prior trauma and fracture with kind of bulky heterotopic ossification and now like marked ischiofemoral impingement. Like there's essentially, I don't know, there's probably like 5 millimeters right there.
Yeah, so this is unilateral ischiofemoral impingement in a male, and that's because of hypertrophy of the inferior ilium there. And I don't think this was from prior trauma. I think this was congenital in this particular patient.
Just congenital, okay.
Yeah, very uncommon. Okay, Jennifer.
All right, this is a 52-year-old male with chronic left hip pain. There's cortical irregularity and osseous hypertrophy. It looks like within the lesser trochanter near the iliopsoas attachment. So I'm not sure if this is just a chronic traction or prior fracture.
Okay, what else might be here that kind of looks like this?
This congenital.
That we talked about in the bone tumor section.
I guess it could be an osteochondroma.
Right. This is an osteochondroma of the lesser tuberosity producing ischiofemoral impingement in a male. Right. Yeah. So you can just
you know your tumors.
Spot.
You know your tumors.
Yeah. Okay, Ashu.
All right, there seems to be within the ischiofemoral space, this is not a muscle. It looks almost cystic, macrolobulated. I'd like to see a T2 sequence. Okay, so it's some intertrochanteric bursitis.
Yeah,
it's just fluid
there. Notice there's asymmetry here of the femur on either side, and this is a female who actually had an osteochondroma here, and this was producing irritation, which produced inflammation of the bursa there from trauma. Okay, Michael.
Okay. So I think the finding what we're looking at is right there along the medial aspect of the proximal femur, kind of where the lesser trochanter should be. And I don't know if it's just because we're not cut through, but I don't see a lesser trochanter, so I wonder if it's been like injured previously. Yeah. Oh, sorry. Yeah, lesser tuberosity.
An avulsion, right? Avulsion injury. And what attaches there?
That'd be the psoas,
iliopsoas tendon, right? And there's where it attaches, and there's where it's been avulsed off here. Separation right there.
That's the epiphysis.
Yeah. There's what it looks like on the plain film. Good. Jennifer.
This is a 16-year-old male, and he had an injury 6 weeks ago. Here I can see it looks like intramuscular edema near the right lesser trochanter, and there may be a small ossific fragment. I would want to look further for a avulsion fracture, and there's also some edema along the greater trochanter, which I think could reflect some stress injury, although he doesn't have an avulsion of the greater trochanter yet. And then we have a sagittal image, again showing that intramuscular edema.
You mean lesser trochanter?
Yes, but also I think there's some stress changes in the greater trochanter without avulsion. But then there's a lesser trochanter avulsion injury at the iliopsoas attachment with intramuscular edema and hemorrhage.
Well, let me ask you this. What are these dark areas in this, if this is edema within the muscle?
Well, I need to evaluate the lesser trochanter. I can't tell if that's a small avulsion fragment.
Okay.
I guess this
So
could
let me
also be
go
an
back
injury of
here.
the musculotendinous junction.
So
This could be
here's the,
myositis ossificans,
okay, there's the
calcification.
iliopsoas tendon on each side. And if we go down here, this is what it looks like on the right. This is what it looks like on the left.
Okay, so does look like a cortical ossific avulsion fragment
And
of the
that's
lesser
what the plain,
trochanter.
and there are the plain films.
Yeah, there is some surrounding calcification. This is probably some myositis ossificans.
Yeah, so it's a lesser tuberosity avulsion with secondary myositis ossificans, probably from the hemorrhage, the hematoma that developed there. Good. Okay. Okay, Ashu.
Basketball injury. Just looking at the acetabulum here, it looks like there's a little bit of displacement. The line is displaced, that teardrop sign. I think there's a fracture, intra-articular fracture through the acetabulum. It's a little bit more clear here. There's a lot of extensive trabecular edema through the acetabulum. There's a little bit of distraction there.
Oops. Okay. Yeah. So I don't know. I think it's really hard to see the injury here myself. It's right in this area. On the MR. Oops. On the MR scan. What's going on here? On the MR scan, we can see the edema and the injury pattern much better. Right. Hey, Michael, 13-year-old male ski injury.
Sorry, I was muted. I'm assuming the pathology is on the left. So it looks like, I mean, it's a partial dislocation of the left hip on that first image. On the second image, well, we already have an arrow showing that there's a marked widening. So the post-reduction, that widening is probably from like hemorrhage, like a large either joint effusion or joint hemorrhage.
I'm not sure it's due to hemorrhage.
If not, then we'd have to find out why it's wide.
Yeah. So
there's actually
when you see it wide like this, you have to find out why. That's a good point. And it's probably
So
not just effusion. The effusion would be pushed out. So what things might you want to look for?
well, there's got to be something there causing like a mass effect, essentially. And so this is already all labeled, but it looks like there's this hypointense linear structure that's in there causing it, taking up space within the joint space, and it says it's detached labrum and transverse ligament. That's kind of probably detached and flipped up.
Right. That's what it was in this case. And then, yeah. So if you can't get a really good relocation, then you have to worry that there's some structure that's interposed in the joint space that has to be corrected to make sure that you have properly restore the anatomy. So MR scan can be helpful at determining what that is.
That's one thing to worry about is still AVN in this kid.
Yeah, right. Yeah, well, the dislocation of the hip AVN is a common sequela that you have to be concerned about.
I've taken care of at least 10 or so.
Yeah.
I've never had knock on wood.
Good.
But I even developed a mechanism of how to reduce them. What you do is you put them on the table in a supine position, elevate the knee over your own knee, and use their popliteal space over your knee, and use the leg as a lever, and do an internal rotation, and pull on it by pushing down on the leg over your knee, and it pops right in place. Of course, you have to give them a good whack of Femoral, like 100 milligrams, or morphine a quarter.
Good.
It works. Never had one not work.
Excellent. Jennifer,
Specifically, highway is notorious for these injuries due to most motorcycle riders.
Yeah, motorcycle riders were back in the days before seatbelts.
Yeah.
Yeah. Jennifer, what do you think of this case?
Okay, so this is a 20-year-old collegiate golfer with hip pain. We have some, it looks like axial oblique arthrogram images of the hip, and there's some contrast signal intensity along the chondrolabral junction of the anterior superior labrum. This is compatible with a labral tear.
Okay. Yeah, so it's an anterior labral tear. Good. Ashu.
9-year-old male, fell skiing, hyperflexion, direct impact injury, severe pain, negative x-rays. So looking at this right hip, there's obviously a fusion here. There also seems to be irregularity. I don't know if there's a fracture of the ischial ligament, or if there's a fracture. The posterior acetabular rim also looks irregular on the axial images. I don't know if there's injury there and fracturing.
So the Ischiofemoral ligament here is torn. We also have an injury posteriorly here. And this is a patient who was dislocated. And I'm not sure about the bone here. I don't remember that being abnormal. But we can see that there's significant injuries to the capsule in this dislocation.
This doesn't look like a 9-year-old. Is it a 9-year-old?
So it says.
Boy, I'll tell you, that sure as hell doesn't look like it.
I kind of agree with you, John. This is
Where's the physis?
Yeah, it's fused. Okay, last case here.
9-year-olds don't dislocate their hips, as far as I know.
Yeah. Maybe it was 19-year-old, but it was sent to me as a 9-year-old. Michael.
Okay. So this is also a 9-year-old fell skiing.
Yeah.
Hyperflexion, direct injury. Epiphyseal plates, I think, look okay to me. I'm wondering if there's widening of that joint space, almost like the other one I had. It just looks, I'd want to see the other side to compare symmetry, but I'm wondering if it's a little widened. So, I mean, we have extensive like pericapsular edema, and especially in the posterior capsules injured. So I'm wondering if he had like a dislocation, and it's popped back in place.
Yeah, this was a dislocation that popped back in place, and you can see the posterior capsule is torn here.
Yeah.
Alrighty, why don't we stop here, and we'll pick it back up again on Thursday, and try to get through more of the traumatic lesions around the hip. Any questions?
Thank you.